Welcome to our webinar today, The Different Ways TFP Helps People with BPD. Thank you for coming. If anyone would like to start by putting where you're from in the chat. We'd like to see where you're from. All right. Okay, we have New York, Chicago, Detroit. Wow, all over. Thank you. I'm Robin Davis, and it's my pleasure to welcome you to the NEA BPD webinar, The Different Ways TFP Helps People with BPD. The National Education Alliance for Borderline Personality Disorder is a nonprofit that provides education, raises public awareness and understanding, decreases stigma, promotes research, and enhances the quality of life for those affected by BPD. We have the largest virtual resource library online with information related to BPD. We bring together clinicians, researchers, people with lived experience, and family members at conferences around the world. Our signature program is Family Connections, which is a 12-week course for caregivers of individuals with BPD to learn psychoeducation skills and receive support. We also have a course for parents in distress due to their child's previous suicide attempt, self-harm, or other dangerous behavior. This is our Managing Suicidality and Trauma Recovery course. Please feel free to check us out at our website, www.neabpd.org. Okay, just a couple of housekeeping messages. Your video has been disabled and all participants are on mute. Please submit your questions via the Q&A, not the chat. Presenters and panelists will answer as many questions as time permits. Please keep your questions specific to the presentation topic, as this is not the forum to ask for advice for a personal situation you may be experiencing. The opinions expressed today are those of the speakers and panelists. They do not necessarily represent the views of NEA BPD. This webinar is not intended to be therapy or a substitute for therapy. As an education-based nonprofit, this is meant to be educational. We do not intend that anything said will be triggering, and we ask you to exercise self-care. If you do find something triggering, please sign off immediately and tend to your needs. 988 is available in the US 24/7 as a resource. Please reach out to your mental health provider for support if needed. This webinar is being recorded and will be posted on the NEA BPD website within 3 to 5 business days. In today's program, Dr. Chaira De Panfilis and Dr. Richard Hersh will discuss Transference-Focused Psychotherapy, or TFP. They will explore individual treatment for patients with borderline personality disorder and applied TFP initiatives, including its application beyond individual therapy. Dr. De Panfilis is a leading clinician specializing in psychiatry with a focus on personality disorders, cognitive control, and self-regulation in the context of psychiatric conditions. With over 2 decades of experience, she has made significant contributions to both clinical practice and research in psychiatry, receiving numerous awards for her research, including the Walter G. Kloepfer Award. Her work is dedicated to advancing our understanding of the social cognitive patterns of personality disorders and their relationship with other mental health conditions, making her a respected expert in the field. Dr. Richard Hersh is a special lecturer in the Department of Psychiatry at Columbia University College of Physicians and Surgeons. He holds an MD from George Washington University and has completed his psychiatric residency at Northwestern University with a certificate in psychoanalytic training from the Columbia Center for Psychoanalytic Training and Research. Dr. Hersh has served as an attending psychiatrist at Massachusetts General Hospital and McLean Hospitals, as well as an instructor in psychiatry at Harvard Medical School. He later joined Columbia University Medical Center, where he worked as a psychiatrist on the inpatient service before serving for 15 years as the associate director of the intensive outpatient program. Specializing in TFP for personality disorders, Dr. Hersh is a certified teacher and supervisor in TFP. It is now my pleasure to introduce Dr. Hersh and Dr. De Panfilis.
Okay, I'm going to share my screen. Oops. Okay. I'm sorry about this. Okay. Great. Well, thank you so much, Robin and Abby. Can you hear me? And are we okay? Great. Thank you so much for the opportunity to address this group today. It's thrilling to see people from so many different places. So we'll speak for about 40 minutes, and then we hope have time to answer your questions. We have no conflicts of interest to report. So our outline for today's presentation is to provide an introduction to TFP as an individual treatments for patients with borderline personality disorder, to introduce applied TFP, or the use of TFP principles in clinical situations outside of the standard individual psychotherapy modality, and to introduce a TFP-informed psychoeducation program. So this is an overview of TFP as an individual treatment. It was developed in the 1980s and 90s for patients with borderline personality disorder, and has an empiric evidence base for that. It was since extended to what we call TFPE, or extended for personality disorder presentations across a continuum. So not just for individuals with borderline personality disorder. There is TFPA for use with adolescent patients, TFPN for use with patients with pathologic narcissism.
Excuse me, Richard. I'm sorry to interrupt you, but I don't think you are screen sharing, or at least I can't see that. I don't know if the audience is seeing the slides. Maybe we can.
Not yet. There's no slides.
Okay. Well, thank you for telling me. Okay. Hold on. I'm sorry. My apologies. Is it now?
Perfect.
Yes.
Okay,
Yes.
my apologies for that. Okay, so we talked about this overview. So now we're at this slide. These are the key texts for TFP. They include the gray book, gray cover, which is the manual for TFP for BPD. Dr. Frank Yeomans is the first author. Then books by Dr. Eve Callagore, including Dynamic Psychotherapy for Higher Level Personality Pathology, and Psychodynamic Therapy for Personality Pathology, Treating Self and Interpersonal Functioning. So those are all individual treatments for adults. Dr. Yeoman's book for BPD and Dr. Callagore's books for a wider range of personality disorder presentations. On the lower left is the textbook for work with adolescent patients. In the middle is Treating Pathologic Narcissism with Transference-Focused Psychotherapy for patients with disorders of pathologic narcissism. And then on the right, two books about Applied Transference-Focused Psychotherapy, Fundamentals of Transference-Focused Psychotherapy, and then the lower right, Implementing Transference-Focused Psychotherapy Principles, a book released this year, co-edited by Chaira and by me. Okay. What should families know about TFP as an individual treatment? So here's the overview. It's a psychoanalytic psychotherapy informed by object relations theory. It's a reworking of standard psychoanalytic psychotherapy to treat more impaired patients. It's an evidence-based treatment for patients with BPD, as I mentioned. It's manualized. It's twice weekly, 1 to 3 years. And it's anchored by the structural interview, which is an assessment process, and the negotiation and maintenance of a treatment contract. What it's not. TFP is not psychoanalysis. It doesn't use the couch. It's not more than twice weekly for the most part. It's not an unstructured psychodynamic psychotherapy. It's focused on specific treatment goals and not just on self-understanding. It's not supportive psychotherapy. It doesn't involve specific advice and guidance unless there's a need to deviate from what we call technical neutrality. It's not a cognitive behavioral therapy. It has an aim for personality change, not only change in behavior. So there is an evidence base for TFP. This article is a review by Christia et al. From 2017. And the takeaway from this article is that psychotherapies, most notably dialectical behavioral therapy, which I think you're mostly familiar with, and psychodynamic approaches, including TFP, are effective for borderline symptoms and related problems. This is a meta-analysis of a number of different subtypes of psychotherapy. These are studies in 2006, 2007, and 2010 that are part of the evidence basis for TFP. What is this evidence basis? So the 2006 study, TFP and schema-focused therapy, showed that both interventions in this 3-year study showed reduction in all borderline symptoms, increases in quality of life, associated with changes in personality features. Schema-focused therapy had a lower attrition rate and was superior to TFP in certain spheres, but not in improved quality of life. The Clarkin et al. Study in 2007 had TFP, DBT, and manualized supportive psychotherapy. All 3 interventions showed significant positive change in patients' depression, anxiety, global functioning, and social adjustment over 1 year of treatment. Only TFP was predictive of decrease in irritability. TFP and DBT were associated with a decrease in suicidality, and TFP and supportive treatment were associated with reduced anger and impulsivity. Only TFP showed significant improvement in reflective functioning. Finally, the Doring study in 2010 was TFP and local expert therapists. Patients improved in both groups, but TFP patients had lower dropout rates, significantly fewer suicide attempts, inpatient admissions, and BPD symptoms, and greater improvement in personality organization and psychosocial functioning. So one of the emerging trends in thinking about interventions in treatment of individuals with borderline personality disorder is the recognition of the value of sequence treatment. So Troy Kane et al. Reviewed 4 major evidence-based treatments and proposed providing stepwise care through assessment of clinical severity as means of achieving system-wide changes and greater access to care. The takeaway from that article is that no particular psychotherapy is best suited for every individual, and some individuals may want to access treatments in sequence. So it's not unusual, for example, for patients to access a generalist treatment and then having made gains, but perhaps wanting additional gains, to access a specialist treatment. This is, I think, rather than a horse race thinking about psychotherapies for BPD, is the current state of thinking that the importance of flexibility in putting patients together with specific treatments. So I'm going to talk a little bit about how TFP as an individual treatment unfolds. We start with a structural interview, which is our comprehensive assessment intervention. It can last sometimes 2 or 3 sessions. Then that's followed by sharing the diagnosis. Sharing a BPD diagnosis is standard of care for all of the evidence-based treatments for BPD. It involves obtaining parallel information from prior treaters. There are a number of goals in doing so, but most specifically, it helps in informing details of the treatment contract, which is to come. We conduct a family meeting when indicated, and that means in TFP, in any situation where a patient is what we call fundamentally dependent on a family member, financially or emotionally, we'll have a family meeting at the start. And we'll talk a little bit about what the goals are for that family meeting. Then we establish a treatment contract, which establishes the responsibilities of both parties, both the patient and the therapist. And in TFP, the treatment contract is detailed and personalized. It's different than standard office policies. It tries to think with the patient in advance of potential treatment interfering behavior. And all of that occurs before we start the treatment. So the treatment contract, this is just a partial list of all of the different elements that could be in the treatment contract. But most notably in TFP, we have what we call the meaningful activity requirement, which is that we expect that individuals participating in the treatment will have paid work, volunteer work, or meaningful studies 20 hours a week. So this, I think, distinguishes TFP from other interventions. And there are a number of different reasons that developed over time, but that's a key part of the treatment contract, the meaningful activity requirement. So we conduct a family meeting when indicated, as I mentioned. It captures many, maybe even most patients with BPD. The goals of the family meeting are multiple: to obtain parallel information, to provide psychoeducation about the disorder, and Chaira will go into more depth about TFP-informed psychoeducation, to explain elements of the treatment that sometimes to families can seem counterintuitive. Unlike DBT, we don't have intersession contact, usually like phone coaching. We talk in advance about deferring to emergency departments and inpatient psychiatry staff about certain clinical decision making. And some of this is not intuitive to families, and we like to explain it in advance. We address in advance expectable splitting. This can mean patients or families having extreme experiences of the treater, say extreme negative or extreme positive, and we try to address that in advance. It's a familiar pattern. And we describe in advance a range of family interventions. And this is also would be consistent with good psychiatric management, that we think about a whole range of ongoing family involvement, including psychoeducation, family connections has been referenced, coaching, and in some situations, family therapy. We also, at the beginning, determine in advance the frequency of family contacts. We like to build in family contact at the outset, and it depends on the clinical picture. Once a treatment begins, patients are instructed to speak freely with a particular focus on material relates to their goals. And what we mean by goals are concrete goals related to the most important spheres of their lives. TFP therapist doesn't organize session, as is often the case in supportive psychotherapy or cognitive behavioral therapy. This change in format may present a challenge for some patients, requiring the therapist to acknowledge the difficulty in free association and to explore with patients the specific barriers that emerge. What happens during the course of the treatment? Well, we start with monitoring 3 channels of communication. In TFP, we're equally interested in what the patient says, how the patient behaves, and our countertransference, or the feelings that come up for the therapist with a specific patient. We tend to put off acting immediately. We try to tolerate the confusion we sometimes experience as therapists, and mostly focusing on listening. And in that step, we try to name the actors. And what we mean by that is to identify the dominant object relations that emerge, and to listen for what we call role reversals. So this is getting into a little bit of detail about how the treatment works, but our focus is on how the patient experiences him or herself, what affects emerge, and how the patient experiences others, including the therapist. We sometimes use what we call clinician-centered interventions for affect storms, when patients are particularly feeling intensely, often intensely negative feelings. We have a set of interventions that help manage that. And as with all psychodynamic psychotherapies, we alternate using clarification, asking for more information, confrontation, bringing to a patient's attention material that's somehow confusing, and then judicious interpretations or offering hypotheses. So what should families know about applied transference-focused psychotherapy? So I briefly talked about TFP as an individual treatment. Now we're going to talk briefly about using TFP principles outside of a standard extended individual psychotherapy. We know that there are high rates of personality disorder diagnoses and comorbidity in most psychiatric settings, that there's limited training in most residency programs in the assessment and management of patients with personality disorders, that the effects of personality disorder pathology can impact the success of treatment for other diagnoses, and that there are what we call risk management concerns, concerns about negative outcomes and managing adverse events. Worldwide, we know that the number of certified clinicians and empirically supported treatments for patients with BPD is insufficient to meet the demand posed by those seeking treatment. Mental health systems lack the necessary resources to provide these treatments, and therefore most PD patients will receive unstructured, unspecific, inconsistent treatment as usual. In clinical practice, the most severely ill patients with personality disorder diagnoses don't receive an empirically validated treatment. And almost half of BPD patients are found not to be responding to a specific individual psychotherapy. So those are all key points in thinking about the benefits of having clinicians learn TFP principles for use in a variety of settings. So as mentioned, clinicians in acute care settings, shorter term settings, psychiatric and medical, routinely see a significant number of patients with personality disorder pathology. Failure to recognize this as a primary or co-occurring personality disorder diagnosis can be problematic and complicating. TFP provides an overarching theoretical approach, and TFP principles can help improve outcomes and serve as an effective risk management strategy. So applied TFP isn't the same as TFP as an extended individual psychotherapy. We don't have the same goals. We don't expect sustained integration of the patient's split internal world with applied TFP. The assessment process should help clinicians recognize personality disorder pathology, which is often minimized or ignored in situations where doing so is not usually a priority. Clinicians can borrow TFP elements for use on an ad hoc basis when they are helpful in almost any clinical setting. So what's so specific about TFP principles? Why are they helpful for clinicians of all stripes? It's a coherent and organizing overarching approach. It flows naturally from psychiatric orientation to sensitivity to comorbidities and a focus on diagnosis. It allows psychiatrists to address personality disorder pathology and avoid reflexive referrals to costly or often unavailable adjunctive treatments. It can confer skills to manage what some clinicians might consider difficult patients, and it can help avoid familiar pitfalls in the treatment of patients with BPD or other personality disorder diagnoses, including polypharmacy, unnecessary hospitalization, or unfocused or aimless psychotherapy. And finally, the applied TFP approach strongly, very similar in fundamental ways to the emerging alternative model for personality disorders, which is now in the DSM-5 and Section 3. There's a great overlap, as well as the current ICD-11. So in our book on fundamentals of transference-focused, we looked at TFP principles in crisis management, family engagement, inpatient psychiatry, pharmacotherapy or prescribing, the interface of medical and psychiatric treatment, and in psychiatry residency training. In our most recent book, we looked at TFP principles used in emergency psychiatric care, inpatient treatment, day hospitals, consultation liaison psychiatry, group psychotherapy, group psychoeducation, which Chaira will speak on, forensic settings, and outpatient community-based psychiatric services. So in summary, applied TFP offers a coherent package of knowledge, attitude, and skills. The knowledge is a working application of contemporary object relations theory. It helps the clinician identify extreme positions and rapid state shifting of patients with BPD and other moderate to severe personality disorder presentations. It helps with attitudes in terms of acceptance of the expectable confusion sometimes experienced with PD patients, comfort with conveying what the patient can realistically expect from the treatment by way of establishment of a treatment contract or frame, and skills including monitoring 3 channels of communication, identifying dominant object relations dyads as they emerge, identifying expectable reversals in those dyads, and managing periods of heightened affect with containing therapist-centered interpretations. So now I'll stop my share and turn this over to Chaira. Okay.
Thank you, Richard. And I also would like to join you in thanking NEA BPD for organizing this webinar and for inviting us to present on applied TFP. I hope that everyone can see my slides. If not, please notify me. As an example of applied TFP, the ones that Richard just mentioned and are collected in our recent book, I will give you like a brief overview of TFP-informed group psychoeducation. So we will talk about why is it important, so what are the goals of psychoeducation in BPD and allied disorders. I will outline which is the structure of this TFP-informed psychoeducation program, and also a short overview about the topics of the group meetings with a specific example from one of these group meetings. So what are the goals of TFP-informed group psychoeducation? First of all, to improve knowledge about BPD and related disorders, because we all know that we may have, both as patients and both as clinicians, a lot of diagnostic difficulties in recognizing BPD and related disorders because of the symptom heterogeneity and also with the diagnostic overlap with other mental disorders. And also sometimes it's difficult for clinicians to, convey a timely diagnosis. Some clinicians may have the fear of stigmatizing patients, but actually the stigma is likely to be not diagnosing properly so that that person can't have access to the appropriate care. The second goal is bolstering hope for change. by focusing on findings from what we know about from longitudinal studies. There are high rates of remissions of BPD. Recovery is also possible, although psychosocial functioning is more difficult to address by existing psychotherapists. And therefore, one important goal is to convey the notion that change is not only possible, but expected. 3, empowering the patient in a shared treatment decision making with mental health providers. So the goal after the psychoeducation program would be that the patients would understand the importance of an agreed on treatment plan with their mental health professionals, including a shared agreements on treatment goals, crisis management, and modalities of others' involvement in the therapeutic process. So what about the structure of this program we are talking about today, TFP-informed group psychoeducation? For whom is it intended? BPD and other cluster BPD patients, what we call borderline personality organization patients, and we will look at it in a while, excluding antisocial personality disorder. But the program can also be adapted to family members in a different group, of course. We don't do joint groups with family members and patients. How? There are 9 weekly group sessions, can be even a higher frequency in inpatient settings, lasting about 60 to 75 minutes each, and including 8 to 10 persons. And the group leaders are 2 experienced coordinators, and please note that they are coordinators, they are not therapists. This is not a group therapy. So for instance, one coordinator could also be a nurse, but the requirement would be to be experienced in BPD and also in group management in a way. And the climate is kept informal and collaborative. The modality is to collect information directly from group members, and then the coordinators will have to summarize, organize, and clarify it. And we don't use slides, but all the information is written down by the coordinators on a flip chart in a collaborative stance. So when do we do TFP-informed group psychoeducation? When can it be appropriate? This slide is exactly the same, but just a different format from what Richard just showed you. So this is the usual treatment flow in TFP. So we first do a structural diagnosis. We share the diagnosis with patient and family members. We do a timely contact with prior treaters. We identify treatment goals together with the patient, and then the contract and the treatment can begin if there is an agreement on the contract. In this context, psychoeducation is really helpful in this stage. So after we shared the diagnosis with the patient and family members and before we start treatment. But even outside the TFP setting, this group psychoeducation program can also be thought as a standalone first step in treatment, regardless of the treatment the patient will undergo. So what are the topics of this TFP-informed group psychoeducation? We have 9 meetings. The first one focuses on the rules of the group and on the treatment frame. Then on the personality disorder diagnosis. The third one on etiology and developmental issues. Then the comorbidities, pharmacotherapy, very important to be clear about what we expect from pharmacotherapy, which is often, the impact of pharmacotherapy in BPD is often negligible, and that should be clearly stated. Then introduction to the various types of psychotherapies, evidence-based psychotherapies, and a more specific focus on TFP principles, and then crisis management and a concluding meeting, and also evaluation of the program. Regardless of the meetings we are talking about, of the specific, meeting, every meeting starts with what Michael Remtrop, who is, one of the developer of this program, and he's based in Munich, a great colleague, a psychiatrist and a TFP and DBT therapist, actually. Every meeting starts with a warm-up exercise. This is quite common in psychoeducation programs for different mental conditions, like, for instance, bipolar disorder or schizophrenia. But in that case, usually the coordinators would ask, how are we feeling today? How do you feel? That is not appropriate for, BPD patients who are often really overwhelmed by negative feelings, and they feel invalidated by their social environment. So the warm-up exercise in this case is, what was the best thing happening to me since the last meeting? At the very beginning of the program, many patients would say, well, nothing. And so we should ask them, think to that more closely. Do that like if you were using like an electron microscope to identify the slightest, the littlest positive thing that happens to you since the last meeting. This is very important and also supported by recent research showing that BPD patients really find it difficult to, notice and evaluating positive feedback from others and positive cues in their social environment. As an example of the 9 meetings we just outlined before, I thought I may share with you something about how we, share the diagnosis of personality disorder in the second meeting. So at the beginning, the meeting starts after the warm-up exercise by gathering information from the participants about the personality disorders diagnosis, but also other comorbid diagnoses they might have received in the past. And this is useful because many clinicians are actually reluctant to share a personality disorder diagnosis. And therefore, there is a strong need for a clarification of what it means to, receive a PD diagnosis, and also for a clearer definition. So if we want to define personality disorders, we like to start defining and discussing what is personality. And we found helpful to use the words of our ISTFP president, Dr. Yeomans. He says that, personality is just about the automatic, instinctive way that we think, we feel, and act, and this comes naturally to all of us. And we become who we are because over time, based on repeated interactions with others, we incorporate a series of images, of representations of ourselves in relation with someone else, with others. And thus, personality is exactly this series of internalized images of self and others, which give us a sense of self and others that may or may not be accurate. When this sense of others is accurate, we in TFP, we talk about a healthy personality organization. Here you can see this yellow circle, and inside there is the view of myself, which is including both positive and negative aspects. And also the others are seen as accurate and also complex individuals with both positive and negative aspects. So in the case of a healthy personality organization, we have a stable knowledge and awareness about strengths and weaknesses of oneself and important others. And important others can be everyone, close relatives, family members, friends. But what is personality pathology? Personality pathology occurs when the internal images of self and others do not correspond to reality. And in this case, the sense of self and others is often not accurate. And this is tragic because when this happens, individuals live more in response to their internal images that are different from reality than to what is really going on around them. And the severity of personality pathology really relates to how large the gap is between an individual's internal representations of self and other and the external reality. And this is the case of borderline personality organization or identity diffusion. This organization encompasses more personality disorders than just BPD alone. And when an individual is organized at a borderline level, at one moment he's just aware of a self-representation and another representation affectively polarized. So in one moment he sees oneself and the others as totally negative or bad, and in another moment as totally positive or bad. So these representations lacks of accuracy and complexity. And importantly, when this happens, the perception of oneself and important others is not only distorted, but also changes from moment to moment, exposing the individual to intense suffering and emotional shifts. When we understand the borderline pathology as, being organized at the borderline level of personality organization, we can perhaps understand better BPO patients' current subjective experience, which is often polarized in a negative view of self and others. So often our patients feel victimized, abused, and the others are seen as malevolent and rejecting. There is this strong feelings of being abandoned and rejected. But we also can understand better why, for instance, our patients come to see us in treatment, and also they are desperately seeking for the others, because separated and splitted from these representations of self and others are negative, there is also very important self and other representations as the self as needy and longing for love, and another that the borderline patients really want to find and is seeking for, and who is seen as a perfectly caring other. So some conclusions, tentative conclusions for the TFP-informed group psychoeducation program. TFP principles, so we are talking of applied TFP, not TFP as a standard modality of psychotherapy, can be used to convey to patients and potentially family members a comprehensive and structured information about personality disorder pathology, etiology, course, comorbidities, and available treatments. The program aims to increase PD patients' motivation for treatment, and therefore it both represents like a guide for a new patient who is coming to treatment for the first time, but also can also show a way back to treatment for those patients who were unsatisfied or who did not benefit from previous treatments or had a history of dropouts from previous treatments. And the program also aims to promote a solid knowledge of the disorder and also an active responsibility in treatment for patients, as well as a realistic hope and expectation for change. I would like to thank you for your attention on behalf of both me and I think also Dr. Hersh. Thank you.
Thank you both so much for this informative presentation. We have a lot of questions coming in. We're going to ask that if you do have questions to please use the Q&A, which you'll find on the bottom of your screen. There should be a little button with a question mark that says Q&A. We ask that you put your questions there. So I'm going to throw out a couple to you, and we'll see how many we can get to. So we have a question about the evidence based around it and what percentage of patients, hopefully leading to remission, respond to TFP from research. Do either of you know the answer to that?
PR, do you want to take that?
Okay, so research in TFP, as for all the other evidence-based therapies, comes from randomized controlled trials. So to answer that question, we should look at randomized controlled trials results. There is, during randomized controlled trials, there is always a proportion of patients who drop out from treatment. And the During and Tal study that Richard showed you before exactly had that outcome in mind. So to investigate whether TFP resulted in a lower proportion of dropouts than, experienced psychotherapy by experienced therapists, and this was the case. So in terms of the exact proportion, I can't tell you, and I would suggest you to look at those specific trials. But in any case, the percentage of remission and also of reduction of suicidal and parasuicidal symptoms is always higher than the control conditions. But I really can't tell you how much is the proportion of remission, because it really depends on the criteria that have been used as endpoint, primary endpoint in a given trial, which is different from the definition of remission that is commonly used in naturalistic longitudinal follow-up studies. I'm aware that this question that this answer is not completely satisfying, but I don't want to, sell something that I'm not sure of.
No, thank you for answering that. We're getting a lot of questions on where to find a therapist, and I believe you had shared a website at the last on your last slide of an organization that has a directory listing. The website is istfp.org. And please check that out and see if TFP is in your area. We're also getting a bunch of questions from people who looks like they may be a little bit familiar with DBT, and they're asking whether they should be doing TFP and DBT side by side, whether, the patient should be doing both at the same time, whether one should be done first, then the next one next. Is it the same therapist who does both? Is it two different people? So can you just discuss that?
So I just as an aside, there's so many great questions. It's just so appreciative of the interest of the group. So in TFP, we would be very supportive of a patient accessing something like a DBT skills group to run concurrently with TFP. But we wouldn't be supportive of two primary therapists, so not a primary DBT therapist and a primary TFP therapist. The reality is that for most patients, because of the more widespread availability of DBT, and then particularly DBT skills groups, many, if not most of our patients have been exposed to exposed to DBT, and some make tremendous gains and want to do additional work in a modality like TFP. Some less so. So in a way, kind of naturally, we're seeing sequencing of treatments, which I referred to from Dr. Troy Kane's article. But in TFP, TFP is supportive of other of AA, couples treatment, other 12-step programs, and is open to that, and something like DBT skills.
Thank you. Richard, I know you said you saw the questions. Is there a question you had in mind answering? Because I'm happy to keep throwing them out at you, but if you have
Sure.
one.
Here's just one really good question. Could you explain the meaning of transference in the name of the therapy? So I'll try to do that. And maybe Chaira can also join in. So the observation, so TFP, there's another question about how TFP developed, and is this related to more traditional psychoanalysis? TFP developed because Dr. Kernberg and other researchers found that standard psychoanalytic treatment, which was really the dominant modality in the 50s and into the 60s in this country, really didn't work for individuals with BPD. In fact, it often made things worse. So Kernberg and his group started to refine, take some elements of traditional psychoanalytically informed psychotherapy, but also make a lot of different changes. The word transference means the intense feelings that many individuals with BPD feel about their treaters that emerge very rapidly, can be intensely positive or intensely negative, but very strong feelings that then tend to dominate the treatment. And this would be different from patients with more circumscribed, with presentations with more circumscribed areas of difficulty, where they would not have such intense feelings that emerge in relation to the therapist right from the start. In TFP, we think of this emergence of these elements of transference as very valuable areas to explore during the course of treatment. Chaira, you want to add to that or qualify that?
No, well, I would agree, but if I can bridge this to another question that I saw in, the Q&A box that I think can be related, because, transference, we understand transference in TFP and in applied TFP. So when we use TFP principles outside the formal psychotherapy, okay? Transference is what is different from what we would normally expect in a similar circumstance by every individual. And this has to do with what we call the internalized representations of self and other during time that in the case of the borderline personality organization are, distorted, not accurate. There was a question on the chat, and I think it is a really important one that we should answer that, that this could be intended as accusatory toward, family or attachment figures, but we don't mean that, because what is internalized is not really reality, but how reality was registered in the mind of that particular person. So the question in the chat also inquired about the role of genes, and of course genes are implied, and BPD, as any other mental condition, as a really multifaceted etiology and multiple risk factors. But what we see as a result is the transference, which is distortion of self and others representations and interpersonal reality. And this is what we see at the end.
Thank you. So we get this question a lot. So I'm gonna ask you. The question is, how do you address patients that are in denial of their diagnosis or condition?
So in TFP, we don't insist that patients accept the diagnosis. We offer the diagnosis and but we don't require that patients accept the diagnosis. Right. Chiara, want to add to that or?
No, well, yes, in TFP, sometimes, the awareness develops later on, and also the acceptance of the diagnosis. In applied TFP programs, probably in some settings, there is more emphasis on, really having the patients understanding their diagnosis, and this is the rationale for the psychoeducation program I showed you. But yes, we don't want to convince anyone immediately.
So Richard, this may be more of a question for you because I think this is US based. We're getting a lot of questions about whether insurance will accept, pay for TFP coverage and whether TFP clinicians accept insurance and whether it's affordable in the United States.
So I think this is a big problem with TFP. There's a problem about number one is it's difficult to train in TFP. Takes a long time. It's not as widely disseminated as we would like, there's a wide variety of whether clinicians will accept insurance or not. I think one of the something that prompted the growth of applied TFP is this realization that this is an expensive treatment to learn and then to provide, but that the principles can be useful in lots of different settings, and that you don't have to provide a twice weekly 1 to 3 year treatment. That's quite a commitment in order to use the basic principles in a constructive way. And that again is that there's a question about what's the difference between TFP and applied TFP. And TFP, that's an individual treatment. In applied TFP, it can be using those principles in the emergency room, the inpatient unit, other places where patients are seeking treatment.
I think we probably have time for one more question as I'm watching the clock here. We have a question here regarding medications. We had a couple of questions regarding medications. So I wasn't fully listening, but someone here said that you mentioned medications are not believed to improve or help BPD. How does the relationship between psychopharmacology and TFP? What's the relationship?
Who's going to answer this, Richard?
You go first, and then I'll chime in, Chiara.
Okay. So what the evidence tells us is that at the moment, there is no evidence that any medication can change the nature or the course of BPD, okay? So the treatment of choice is psychotherapy, and the use of medication, if you read all the guidelines, should be restricted at limited time periods, and polypharmacy should be avoided based on that research evidence. Unfortunately, in clinical practice, many, if not most, BPD patients receive, a lot of prescriptions for medications and sometimes polypharmacotherapy, which is a problem that we as, mental health professionals should, address. So in TFP, and then I will leave the word to Richard, it is important to, from the very beginning to tell the patients that medications, about the limits of medication. Otherwise, you are fostering an unrealistic hope that medication can fix this condition, why this is not the case. But Richard, please.
So TFP skills should be able to help prescribers, and that includes psychiatrists, nurse practitioners, primary care doctors, avoid unnecessary medication, and to help manage the feelings that emerge for the patient and for the prescriber in this context. And that's a perfect way to end to talk about a specific applied TFP intervention. Anyway.
Yeah.
So
Thank you both so much for your presentation and for joining us today. I know we had a lot of questions that we weren't able to answer, but we can do some more trainings and more webinars on this to get everyone else's questions answered. But we thank you so much for being here with us today.
thank you so much for the opportunity. Yeah. Okay.
Thank
Take
you.
care.
Thank you very much.